Thanks very much. I've only got 15 minutes, so it's going to be a bit of a canter through all of this. Mobile health is all about using...
Can't slow down as well a bit because the next person's
Not here. Oh, thanks very much. Oh, I've got 45 minutes. Tough. So, so it's going to be about mobile health. It's all about using this kit here to do wonderful things. I feel like Madonna with this headset on. I might start singing. You never know. So, a little bit about the trust, and to put some context, we're called Oxford Health. We do mental health, we do community. We mostly do it in Oxford, but we do cover a big part of southern England. And as you'd expect, there's lots of stats around the trust. Draw your attention to the fact that more than a third of what we do in a patient's home. That's quite important. And what's slightly different is that we've got an awful lot of iPads in the organisation. So I put this slide up just so that people realise that when you get CIOs standing up here, people think, oh, do you really know what it's all about? This is, in essence, 21st century healthcare, but the take-home message from this, actually, is the best bed to be treated in is your own bed. I've got to be careful, because I once said the best bed to be treated in is my bed. What I meant to say was the best bed for me to be treated in is my bed. So the best bed is your own bed. And that Matthew this morning was saying that. I think that was one of the key messages that came out of his presentation this morning. We all know that there are lots of policy changes. I'll save you the bother of reading these documents. The message is we need to do things differently, and we need to have interoperable records, paperless at the point of care. All of these things are challenges that we need to address as organisations. This is a particular challenge. We're a very rural organisation, so this is back in 2013, start of our journey, and this is a CPN, and in essence, they go out and back, and if you've ever tried finding parking on an NHS site, 20 minutes is not uncommon. That's quite important, just for a couple of slides later. The other thing is the device challenge. So I'm a former clinician, and when I was a jobbing clinician, I used to say, the patient is at the centre of everything I do, but of course nowadays the computer is at the centre, and I thought, no, that's crazy, and then I thought, no, actually that is true, and this was my road to Damascus experience, because I thought if that's a fact, then we need to make sure it's the right device. So how did we get to where we're at today? It wasn't an easy journey. This is what happened. I developed this as a proof of concept. Back in 2002, I was doing a software engineering master's back then, and that was my dissertation. It's a patient record, proof of concept. It morphed into a BlackBerry application, very safe, very secure at the time. National program came, so we had to go back to using Internet Explorer and smart cards, and now we've gone to what I would consider to be the best sort of mobile computing device on the market. So, and it's iPads, and that's a bit like looking at a picture of yourself when you were much younger, isn't it? I was a new romantic, and I look back and I go, did I really look like that? But that was the reality back in the day for all those millennials in the room who can't imagine it. So, the thing about these iPad devices, you can have benefits on day one. You must manage the device, and as soon as you manage it, it's safe, it's secure, it's encrypted, you force policies on it. But straight out of the box, we give people device. When we started to do this, we rolled out 2,000 in 3 months in 2014, and everybody came in not having a device, and everybody left knowing that they were going to get benefits straight away just by what you get out of the box. And the biggest thing you get out of the box is access to the App Store. So, the gift of time. Everybody would like to have a bit more time. Here's a little equation. We do wonderful things in the NHS, but what we also do is we can overcomplicate things. UPS, big firm delivery, said they need to save money. What they said was if every driver drove 1 mile less per day, they would save £50 million a year. And so they ran some algorithms and what have you, and they said if the drivers turned right instead of left, they would make that saving. So just keep it very simple. 30 minutes a day. Average band 5 cost. Most of our iPads are with clinicians at band 5 rate. If you work that out, in a year, that's the value you're talking about. There's an £8 million productivity gain there, potentially. Or to put it another way, the cost of the device, you get an ROI in 57 days. So after 57 days, if it can give you 30 minutes, it's saving you time. So I'm going to show you how it's going to give you 30 minutes, and I'm going to show you how it's going to save time. Nothing wrong with Windows, we still use Windows, but we started with Windows XP. If you remember logging on and off to Windows, you used to log in, make a cup of tea, come back, and it would be ready. You can work that out, 7 days a year is spent doing that, or to put that another way, £3.7 million worth of time. If you compare that with iOS, you can log into these in seconds. So in essence, you're saving 7 days, just on logging in alone. If only half the people logged in and out 1 time less per day, that's a big saving. So this is how you make the business case. It's very straightforward. The other big saving we had is that we have a big estate of Windows devices, and we were replacing them every 5 years, 20% on average. We were spending a lot of money, and over the last few years, that's what we've been spending. So we've avoided a cost of 1.2 million. So if there's any doffs in the room or anyone who says, is there a business case, a financial business case for this, the answer is yes. But that's only one part of the story. The big part of the story is the qualitative benefits these devices give. So the camera, out of the box, it costs you nothing, you get it out of the device. Our staff are doing fantastic things with cameras. District nurses are taking pictures on taking pictures today on old cameras of wounds, going back, uploading them, going down the next week and go, oh, I don't have the picture. Now they're taking a picture on their iPad, they've got it with them. But not only that, they started taking pictures whilst they're in the house, sending them to their colleagues, saying, you saw it last week, is it better or worse? And that's morphed into they're now FaceTiming. They're sitting there with a FaceTime on, saying, what do you think? I think it's got better. Does it look better? So the camera is a fantastic thing. The camera is about stills and videos. One of the best stories we've got is our learning disability. One of our learning disability nurses was called urgently to a school because one of our learning disability children who had autism wouldn't leave the classroom. Just wouldn't leave. So we went there, tried to persuade him, couldn't persuade him. Transport waiting outside. So he got his iPad out and he videoed the journey. He brought it back and he replayed it. And it took 4 times replaying it, but eventually the young guy was able to say, that's fine, I will now go and take the transport home. What would have happened had he not done that? We like the camera so much because people were recording their sessions with patients that we actually worked with a company and created an app. What this app does is you get the patient to sign it and say, yep, I'm agreeing to all of this. You video your session, it compresses it, it uploads it securely, and then you can review it, if you like, from a cloud setting. So that's the camera. I mentioned a little bit about FaceTime in terms of wounds, but video conferencing, we have got staff, this has been transformative in terms of staff using it. We have got staff who do one-to-ones just using FaceTime. Sometimes you go into a meeting and you will see 6 iPads lined up because 6 people are talking to 6 people somewhere else. And they're even turning the iPads to face each other so people can talk to each other. We're going to make that an awful lot better because we're going to use Skype in a one-to-many relationship. But the point is, you can do this. I've invested a lot of money over the years in video conferencing that just gathers dust in the corner. I'm sure other CIOs will have done the same. But the best thing that's happened for this is this what we're calling the technology-assisted psychiatry. So if you can imagine, we've got a psychiatric liaison service in the local emergency department, and it also covers a hospital 25 miles away. You turn up at the hospital 25 miles away, having tried to kill yourself, cut your wrist, taken an overdose, you have to be assessed. It can take an hour and a half for someone to get there. You're sitting there in a very distressed state waiting, if indeed you do wait, for someone to get there. And remember, once they get there, they have to find parking. So what they did was they've used iPads. They literally set up iPads in 2 different areas, and they now do an awful lot of the consultations remotely. And here's the findings. There's a video, I don't have time to show you, there's a wonderful video about this, but the bottom line here is the reluctance was staff reluctance, not end user or patient reluctance. We're talking about blueprints today. The blueprint message here is get your staff using the technology before you get your staff talking to patients, because then they will see the benefit. So that's simple stuff. All of these applications are available on the App Store. Our speech and language therapists, children's speech and language therapists said to me, oh, thanks for these iPads, they're fantastic. I said, well, could you tell me what you're doing with them? He says, oh, we're using apps. I said, well, give me a list of the apps. They've got spreadsheets saying what app to use when. And they've done nothing but encourage people to download these apps, but then they picked the phone up to some of the app suppliers and said, you've got a fantastic app. If you would only do X, Y, and Z, it would be even better. So suppliers have started to change their apps based on the feedback. This one is a bit of a joke putting this up. This is where we're supposed to say there's lots of perverts in Oxford Health looking at hosiery. I did intensive research into this when I saw it. So this is an app. Does anybody know what this app's all about? It's about surgical stockings. The reason for putting this up here is that nobody told any of our district nurses to use this app. And within a couple of weeks of them getting iPads, 47 of them had downloaded. This is back in 2014. Now it's almost 200 downloads. That's almost every district nurse. So word of mouth has spread. So the point I'm trying to make with this here is that people are finding apps that are really useful in healthcare themselves. Previously, they would have had to phone the IT service desk and say, oh, I found an application, I want to download it, and we'd say, oh, we need to package it, we need to check it, we need to do everything. They're just getting on and doing it. And it's making a big difference in terms of treating ulcers. The other thing that's happening is that you can download this from the App Store if you want it. It's called Let's Talk FGM. So FGM, it's a pretty disturbing thing to be happening. One of our health visitors has a real interest in this, and so she's created an app. And the idea of the app is you're able to have a conversation with someone who often don't speak English as the first language. So there's lots of things, and they've got imams, etc., talking about what the religion is around this. So it's a fantastic app, and that's really helping quite a lot of people, because the statistics are frightening there. The other app that we've created, Professor Paul Stollart's created, is Blue Ice in case of emergency. So this is for young people who self-harm. Again, frightening statistics, but one thing we've noticed is that they usually have a smartphone with them. So rather than telling them you should do this, you should do that, what you do is you work with them. It's a prescribed app, if you like, to work out what's going to happen when you start getting these thoughts. So instead of reaching for something to cut yourself, you reach for your iPhone and or indeed your Android as well, and you work through what it is you've already agreed that you should do when you start getting these inclinations. So that's Blue Ice. This is another application created. This is all about patient outcome measures. There's like 30,000 of these recorded, and it goes way back for many years. And the idea is we're using it in our iApp services. You know, you hand the iPad, and the children say how they're feeling. So it's all about outcomes. Are we being successful? We've tried to work a bit on this. This is the first series of the Apple Watch, and it was recreating this, but on an Apple Watch. So the idea is you're rating your mood. So the idea is when you come to see us, we don't have to say, how have you been? We already know, because we've got streams of information around you. So it fundamentally changes the conversation you can have. This is our electronic health record. It's called Care Notes. These are some screenshots on an iPad in a browser. Great. This is like a general assessment. The 2 speakers ago was talking about assessment. This is how we do our assessment, and people are doing it live. Logged into the browser, sitting in a patient's home. This is how we're doing news, so you have some conditional logic. What I want to point out here is that this is just a holding page. It says GP info. You can be sitting in someone's home on your iPad, you click GP info, and you're using the MIG to access GP information. So that's been revolutionary. There's thousands of access to that in the first few weeks of Go Live. And all of this is happening on an iPad in the patient's home. There is an app from the same company, Care Notes app. This is disappointing insofar as it's good for what it does, but less than 1% of all transactions happen on this app. So the lesson there is that we need to do more with the company to help them build this app. Whereas their application in a browser, very successful. So there's some screenshots. Now, has it been plain sailing? More or less, actually. You'd be surprised. There's 15% more breakages than laptops, but that means people are using them. And the other thing is, we didn't buy very good covers. I quite like minimalist, and I was saying we should have these covers here, and so people are dropping them. So there is more breakages, but more people are using them. It doesn't take an awful lot more resource to deploy them. You have to manage them, is basically what this is saying. But we have to work out how to do this here. This is possible, which is that's our next step, which is on wards, giving them to having a set available, maybe 10 iPads per ward, so the people own them for the duration of their stay. So are we getting positive feedback? Yes, we are. People are doing twice the amount of work possible. We're keeping wives happy, which is always a good thing, or husbands indeed. How many times have overworked NHS staff said that they feel valued? Not a lot, but they're feeling valued if we're giving them iPads. Nobody's ever offered to give me a hug when I gave them a laptop, so this is really good stuff. Now, we thought we were doing really good things and had covered off everything, and we've stopped using Windows XP, we're using Windows 7 and 10 now. And a couple of weeks ago, at our digital strategy board, one of the professors at Oxford who does occasional clinics said, terrible experience in our patients. It's a desktop, I have to face it rather than the patient. I forget my password because I only go there once every 3 months, blah, blah, blah. I said, well, that's crazy. Here's an iPad. So we gave him an iPad. And just out of the blue, he sends me this note. Now, the first thing, he doesn't always call me darling. We're very familiar, but we're not that familiar. My iPhone calls me darling. That's another story. But there you go. That's his feedback. I thought we had all these bases covered, but it turns out that even with Windows 7, Windows 10, all these faster things, it's still not the best thing. And just give someone an iPad, 4G connected, and they start doing wonderful things. And that's all I have to say to you today about mobile health. Loads of questions.
Dominic, that was fantastic, and a really good description of what can be a very, very difficult space in which to work. I know our work around digital ecosystems is very innovative, but equally requires quite careful management in terms of how the program is run. So I'm sure there are an enormous number of questions for Dominic, so please feel free. We've got at least 10 minutes, so please take advantage of the time.
Behind you there, Brian.
I think you showed something transactional with care notes, and you said that the take-up was really low on that, but I didn't quite get what that bit was about.
Yeah, it's it's the iPad, the native iOS app. So, cracking little app. It does very focused things, and so people are saying, well, yeah, that's fine, but actually, I can use the browser. And shall I just give you a quick demo of why the? If you're familiar with the iPad, I forgot to bring my connector. Had the irony, I forgot to bring my connector for HDMI today. So if you're not familiar with iPad, that means nothing is loaded in the background. So it's completely empty in the background. There's nothing up my sleeves, ladies and gentlemen. I'm going to press this. This is going to establish a VPN and launch. I'm using Touch ID. Launch a browser. That's secure. I go into the bookmarks. I press the bookmark. And now I could be sitting in a patient's home, and that's how quick we can provide access to the clinical record. So the iPad is about being able to be offline as well as online, but actually we're finding that people are saying, I'm mostly online, I can do that. So they're just not using it, but we need to do more with it.
Hi, Dominic. I do have to ask. You talked about advantages of having iPads and nice things. Is there anything you don't like, or what presented as a challenge when you started rolling out these mobile devices?
Yeah, and being Oxford, what we did was of course, we evaluated it, and we had a PhD person come in, and they were doing it, and they've written it up, and it is going to be published. And the challenge we had was people were saying, what's the catch? And that's genuinely the challenge. We rolled things out very quickly, and we had some difficulty getting these devices into everyone's hands because people were going, what's the catch? And about 100, 150 on average sit in cupboards. So you still have to manage them. You still have to manage people to use the devices because some people will not use them. But if your question was about versus other platforms, that's a different question.
No, I didn't mean other platforms. I meant just in every day-to-day use, because rolling out mobile devices, how do people forget them, lose them, drop them? Do you have bigger pockets in the...
No. So this is all down to how you deliver them. So what we say is corporately owned, privately enabled. So we own them, but we want you to own it. And so it's your Apple ID. You can use your home ID, or you can create one specifically for work. But it's about you. And again, people are going, oh my God, can I download, and of course people download all sorts of apps on it. And we're saying, yeah, just do that, use it. And we're not having a problem with people abusing it. There's a couple of times that people were streaming stuff they didn't know they were streaming stuff. You have a word with them and they go, oh, that's fine, I'll just use Wi-Fi. They had gone home and hadn't put it on their home Wi-Fi, and they go, oh, I didn't know I could do that. So there really are very few downsides, but you do have to still manage people, yeah.
Sorry. Do you have some sort of mobile management setup?
Yeah. So we've got an MDM platform that we use, and the one we use is Mobile Iron.
Sorry, Mobile Iron.
Mobile Iron.
Ah, all right.
It's my Irish accent. Mobile Iron, IRON. But there's Jamf, there's AirWatch. They all do similar things.
So if I understand correctly, you actually give these out to their personal devices.
Yep.
So they take them home. They're
Yep.
the ones in charge of
Yep.
charging them and
Yeah,
so on.
take them on holidays, whatever they want to do.
And have remote access on those. So while you're away, you can check in with your patients.
And that's the quid pro quo.
Very good. Thanks.
I have a question about your apps that you were talking about. A lot of your feedback was from staff. What about the patients? What are they saying? Do you have any real-life examples of where things have actually changed for the better because of your apps, or are you still working on things?
Yeah, I mean, I did rush through some of the feedback I got, but they're using it with children who to distract them whilst they're doing things with them, and that there's really good feedback from parents. Then one of our staff members brings his Apple TV with his iPad wherever he goes, and he will sit in the patient's home or children he looks after with the parents, and he'll be demoing stuff on their screen. He says, "Can I plug it into your HDMI cable?" And he demonstrates. And the feedback from that is, this is just fantastic. You were able to access so much information. So it is good. And the Blue Ice app, that was developed with children. So it wasn't something that we did. And the FGM app, that was developed with end users as well. All right.
Any more questions for Dominic at all? Okay. Well, there we are. Thank you.
You use information across different services, mental health, community, GPs. What about the data protection laws? Because my understanding is there are slightly different laws in community and mental as well as... there's no issue there, is there?
No. So
okay.
We have all the information governance. No, I hold still. All the IG is in place to enable all of this. So we're not doing anything that's outside proper processes. Okay.
So thank you, Dominic. I think that's an extremely powerful story. I'm actually going to volunteer, Dominic, he doesn't know it yet, for one of our blueprints. I can think this is something which should be scalable across the NHS, so Dominic has just won that allocate. That ends this session now. We will regroup in half an hour. On the way out, can I ask you please, if you have the time, to stop by with Kate and Ian to complete our survey around GDEs and blueprinting. It's really important that we understand what the perceptions around this program are, so we can better tailor it to the needs of the digital community. So Ian and Kate have got a few iPads there. Survey will take about 3 minutes. Thank you.